I put this case up just to show you that even though this abscess is very anterior, it looks very accessible due to the patient size, you can't really see it under ultrasound. So again, we have to revert to CT to do this case. This case is just to show that you don't need a whole lot of window to put in a drainage catheter. Here's a lesser sac abscess from pancreatitis, and we didn't need a whole lot of window to get through there. Just a couple points about prostatic abscess. It's not very commonly seen, but when it happens, it's very uncomfortable for the patient, and the patient can appear very sick. And what should you do in this case? Obviously, the patient has to be on antibiotics, but in addition, you need to do a transrectal aspiration. Most of the time with prostatic abscess, you don't need to put in a drain. All you need really is to aspirate out as much pus as possible and then continue the patient on antibiotics. So just some pearls. Manage all the catheters you place because it's your business. Try not to inject contrast immediately after placement of catheters unless you think you're in the bowel or whatever. Just to be safe, then you can inject a little bit. Liver abscess, you can aspirate or you can place catheter. Pancreatic abscesses require larger catheters in general. With pelvic abscess, determine the safe route. And prostatic abscess usually requires aspiration alone. All right, I'm going to change topic here. We're going to talk about percutaneous biliary intervention. It was developed in 1937, and since then it's taken off quite a bit. You can use it to get tissue diagnosis, and in the old days they used to measure pressure, believe it or not, to diagnose for obstruction. So you do it for diagnosis, decompression, and adjunctive biliary intervention. Indications to relieve symptoms as listed above, and also diversion of bile flow, as in biliary fistula. Other indications include route for other biliary procedures. You can get access so that you can do stricture dilatation, stent placement, stone removal, or brachytherapy. Contraindications to percutaneous biliary procedure is basically the same as abscess, uncorrectable coagulopathy. In addition, extensive hepatic metastasis is a relative contraindication, and then patient with ascites is also relative because you can drain the ascites first. Workup includes the above LFTs, review of imaging studies, antibiotics, and most of the time we use conscious sedation unless it's in a pediatric patient, then we use general anesthesia. Access route, you can either go right, mid-axillary, intercostal, usually the 10th intercostal space or 11th intercostal space, or subcostal even. In the left side, usually we go subxiphoid to avoid the pleura. Sometimes bilateral access is needed, as in Clatzen's tumors, to decompress both sides. You can enter the duct with a 22 gauge needle, or you can get fancy and use a 25 through the 22, and then you'll pacify the duct. Make sure you're peripheral, because the more central you go, the more complication you would get. You secure the access with an 018 wire and then exchange up to a working wire, 035 wire. And then you negotiate past the obstruction. This usually requires some kind of glide wire. And then you place the internal to external stent, or if you're not successful crossing the obstruction, then you can just place the external catheter. Here's a cartoon demonstrating the internal to external stent. So the catheter spans the whole biliary tree and it goes down to the duodenum. Here's a pediatric case in a patient with a left lateral segment transplant, very difficult case, and we got in to this duct by using ultrasound, but you have to be really trained and you have to spend a lot of time learning this technique. However, it's possible. We like to use ultrasound in peds patient in particular because you can limit the radiation dose and you can also limit the contrast dose. Here's the biliary tree, and here it dumps into the small bowel. It's a loop. And this catheter, again, this is an internal to external catheter. Biliary stone removal. Here's a case. You can see some film defects up here, compatible with stones. On the cholangiogram, it extends over here. And what we do is we put in a wire, and then we use balloons to push the stone antegrade into the small bowel. And here we got rid most of the stones from this branch here. And here's our final result. Looks pretty good. So just go over some numbers. Success rate is 94 to 97% for biliary drainage. Low complications. However, there's a finite number of mortality, 1 to 6%. Major complications is 48%, and minor complication, including occlusion and dislodgement, is a bit higher. Here's a complication from a percutaneous placement of a stent. You see a contrast opacified area here, compatible with the biloma. What happened was there was an obstruction down here, so we kept pushing the wire, and the wire kept buckling up there. And after a while, you have a little pate and a cavity form eventually. Here is an angiogram of a patient post PTC, and on the arterial phase, you see this portovenous system of pacifying, compatible with a portovenous arterial to portovenous fistula. And this one required extensive embolization with coil. And this happens occasionally. Most of the time, there's a string that goes through here, so you get away with it by pulling out, and the string would come out, and then your fractured tip would come out with it. But sometimes that's not possible. So we got up to this point, and then the string broke off, and this piece was left inside the duct. So we had to put it in a snare and grabbed it and pulled it out. How about biliary stent? Flexible wall stent is most commonly used, although there has been a lot of work on cover stent recently, and that appears to improve patency. But the quoted patency for the wall stent is 6 to 12 months, which is, exceed the life expectancy of patients with malignant biliary stricture, which is 3 to 8 months. That's the case when you want to use it. It's infrequently used for benign strictures. Here's a patient that we follow for about 4 years with bilateral tubes placed, and he had sarcoidosis, and sarcoid can present like, the great imitator. It could present like cholangiocarcinoma. There were irregular filling defects all on the duct. And this patient, we kept exchanging his tube every 6 weeks for 4 years before he got his transplant. How about balloon dilatation? We use that for benign strictures, for the indication listed here with pretty decent success rate. And the 3-year patency is 42 to 70%, depending on the etiology of the strictures. Okay, let's move on to percutaneous nephrostomy placement. Indications for nephrostomy placement is relief of urinary obstruction. You can improve renal function, and you can clear infection. In addition, you can also place it for diversion of urine when your urologist, for example, puncture a hole in the ureter. Also, you can divert it from inflammatory or malignant fistula. And the other thing that we do quite a bit of nephrostomy 2-4 is to provide access for our surgeon to do all this fancy stuff. Contraindications, again, is uncorrectable coagulopathy. Obviously, you don't want to go through a tumor either, so avoid tumor when possible. The labs and antibiotics are always obtained and given. We also use sedation in most cases. Complications, 5% overall, with urosepsis of being 1%. Bleeding is 1%. And colonic perforation, if you go too anterior or too lateral, you can go through the colon. Pleural complications can be avoided if you go subcostal, because if you go intercostal, up to 10% can have pleural complications. And then post-obstructive diuresis with electrolyte imbalance can happen. Just keep that in mind when you managing your own patient. Again, the basic technique is pretty similar to the biliary catheter placement, but remember, try to go subcostally and then try to access the posterior calyx rather than the anterior calyx. And you also want to avoid getting into the renal pelvis directly because your complication rate would go up. And then you do a series of exchange, you get up to a working wire, and then you dilate the tract, and then you place a catheter. Here's the avascular plane demonstrated on this cartoon, and that's where you want to go. Here's a cartoon, again, showing access a nephrostomy catheter into the renal pelvis. This is a nephroureostomy catheter, which goes into the renal pelvis and then goes through the bladder, through the ureter into the bladder. Usually we do this to bypass an obstruction there. And we can also place an internal stent through the same route with a double J stent. So the urologist will go in from below while we would go in from above. Some catheter, just to show you, here's a nephroureostomy catheter. Here's a double J stent. This patient had a large kidney stone and is scheduled to have endoscopic removal. And what we do for our surgeon is we go in, puncture the stone, and pass a catheter down into the bladder. And then through this route, the surgeon will do his endoscopic work. And here's the nephrostomy catheter. Here's a patient with a neobladder down here with a long segment narrowing of his distal ureter. And for that case, we can use balloon dilatation. And here's bilateral nephew stent. This is what it looks like. They come in different sizes that you can size the patient for. Here's a case showing a patient with bladder to vagina fistula down here from a cervical carcinoma, and her life expectancy was not very long, so we were asked to put in to embolize the ureter to prevent urine flow distally. And this works in the same fashion as inducing hypoplasia of the cells surrounding the ureter. For a non-dilated system, which is sometimes very difficult to do, a couple of things you can do. You can opacify the collecting system by giving IV contrast. I usually give about 100 cc of contrast, and then wait for the system to opacify before you puncture. The other way is a double puncture technique where you blindly puncture into the renal pelvis, and then with a very skinny needle, and then inject contrast to opacify your renal calyx, and then puncture the calyx secondarily. Another useful thing to do is when you're stuck, you can just bring the patient over in CT and then access the collecting system under CT guidance, and then bring the patient back to the Flores suite. But that gets to be time consuming. So in summary, I think abscess drainage is ranks as one of the most significant development of abscess management since the discovery of antibiotics. It's not very glamorous, but as most of you know, the patient really gets better, and you're doing good work for the patient. Also, from a billing perspective, you can bill pretty well. It pays the bills. And percutaneous and biliary and urologic interventions can assist or supplant surgical procedures. Thank you for your attention.
Ed Michaels, when I was preparing this, asked me to go through sort of this mini lecture, which is kind of how to take a case, and that's something that I think occasionally we forget to teach our residents. We just kind of throw a case up and expect them to kind of negotiate through it. So my own residents have probably heard this a few times, and they can leave if they want. But the one thing to emphasize whenever you're practicing is you need to practice saying the words aloud. You really have to say the words, because you may know it in your head, but until you actually say the words out loud, you'll find that your presentations really aren't particularly refined. You should let your classmates critique your style, and really don't practice alone. So, the approach to an unknown case. First of all, you want to look at it. Take 10 or 15 seconds, look at the entire radiograph, and in terms of an angiogram, you want to describe the type of study you're looking at and the catheter positions. And then you want to succinctly present the positive findings in an organized manner. Occasionally, you want to mention negative findings. For example, if you see an aneurysm, you want to note whether or not you see any evidence of hemorrhage. But in general, stick to the positive and obvious findings. And then you want to start with a differential diagnosis. And you always begin with the thing that you think it is and the most likely diagnosis. And realistically, you don't want to give more than 3 to 5 alternatives. Now, this is not possible for certain things, but in interventional radiology, it typically is. It's also not advisable to sort of save your diagnosis to the last thing for the dramatic effect. You really want to get to it, say what you think it is, and move on. All right, and then after you give a differential diagnosis, you want to discuss what the next step in the workup could be, whether that be to get a CT, to go to surgery, to do angioplasty, whatever. So look at the case, give a differential, describe the next sequence of events. In Louisville, when you hear hooves, you want to think of a horse. Something they're not going to be so obvious that it's not going to try to be hidden a little bit, but think of a poorly hidden horse rather than a well-hidden zebra. You can see I have 2 young children. I spend a lot of time at the zoo. Okay, important don'ts. These are common mistakes that I think are very easy to fall into and mistakes that really don't fly well. First of all, you don't want to start by asking questions. You're the one taking the case, not the examiner. If you have a question in your mind or you're thinking of 2 different things, you can easily phrase it to saying, if the patient was this and that, I would consider such and so forth. You don't really have to say, well, how old's the patient, so on and so forth. So don't begin by asking questions. You don't want to mention things that are impossible. Okay, this makes you look dangerous. Sometimes you've got a diagnosis so well memorized that you just want to spit out the entire diagnosis. You really want to sit down, think about the case, and think about the patient and say the appropriate things. And errors of commission, in other words, saying things that are impossible, are worse than not mentioning things. For example, you wouldn't say if it's an adult, this looks like total anomalous pulmonary venous return types 3, because that doesn't occur in an adult. More important don'ts. Don't mention anything that you're not prepared to discuss in length, and as a general rule, you shouldn't mention anything esoteric. These are common things that you're going to be shown. Don't be vague. You don't want to criticize film quality, except in mammography and nuclear medicine. This is an obvious one, but some people get very excitable. You don't want to argue with the examiner, because at the end of the day, they're the ones that are going to decide whether you pass or fail. Don't become mute. People have a tendency sometimes to just sort of become silent if they don't know what's going on. You often won't get help, and if you are sitting there in silence, you're really not doing yourself any favors. Finally, don't try to bluff. If you don't know something, just admit it. Say, look it up. Go on, okay? There's going to be plenty of things that you don't know. Don't forget what section you're in. If you're in the interventional section and you get shown a solitary pulmonary nodule, you're going to be, more likely than not, they're going to be showing you an AVM. But remember where you are, and they will tell you this. Don't dwell on your mistakes. This is a very difficult one, easy to say, difficult to do, because many of these things are going to fly through your mind as you're going through sections, but you got to just kind of take it and move on. This is something that residents commonly do. Try to make a case fit a differential that they happen to know. They know a differential, so they sort of try to invent the findings. Don't do this, okay? Similarly, don't dwell on things that are equivocal, okay? The vast majority of cases that you will be shown will have very obvious findings, so stick with those abnormalities. Don't forget where you are in a case. In other words, if they show you a few things, you give a differential, and then they may show you a few more studies to limit your differential. Don't go back and give them a different differential. Okay, so remember where you are in the whole thing. And finally, this is by far the most important thing. Don't be dangerous. If you're dangerous, you'll fail. Okay, so you really have to be reasonable. Most everyone at some point in time when they're taking cases is going to get stuck. Okay, and if you get stuck, this is what you should do. First of all, if you don't see the findings, and this may occur, but it's pretty unusual, admit it. Most of the time an examiner will give you some hint to sort of point you in the right direction. Think aloud. Okay? Tell the examiner what you're looking for and what you're considering. Say, I'm looking at this, I'm looking at that, I don't see this, I don't see that. They may try to help you along a little bit then. Look for what's missing. Sometimes it's easier to see what's abnormal in there, and you forget to see the missing kidney. Okay? That's sometimes very hard to appreciate, especially when you're nervous. And finally, just organize and have something in mind for a general differential. The one that I used to use was Cine TV just because I could remember it, okay? Congenital, infectious, neoplastic, endocrine, traumatic, vascular, something like that. Everybody's got some kind of general differential, and remember and think about this and go through these types of things when you're stuck. In Louisville, at the end of your differential, you want to always consider PCP, HIV, sarcoid, and lymphoma. They're extremely much more common there than you will see in daily life. So always at least think about those things. You don't have to mention them, but just think that since a lot of these things can look like a lot of things, I'll at least consider them. And finally, if you really don't know what's going on, just say, I don't know this case, I don't know what's happening, and you'll go on. It's to your advantage to see as many cases as you can, and they'll try to rush you through cases. Okay, let's go through some classic unknowns. The first thing about this, which doesn't make it a classic unknown, is that it's labeled. You won't get labeling in Louisville. This is a selective GDA injection with a little bit of pooling that persisted through the venous phase, and this is diagnostic of active hemorrhage. Okay, so the study is a selective GDA arteriogram. There's extravasation of contrast. The differential for upper GI hemorrhage includes ulcer, tumor, some type of iatrogenic intervention from endoscopy, and trauma. And the workup is embolization, period. If they've gone to angiography, at that point they've failed endoscopy and you want to embolize. This is the follow-up exam. You can see coils have been placed. Usually for this type of bleeding, they're combined with gel foam pledgets. And you see you've preserved flow to the cystic artery, so you don't have gallbladder necrosis, and you've preserved flow in the proximal part of the gastroduodenal artery. As far as the bare essentials of embolization, what you need to know, first of all, is what abnormalities can be embolized. Hemorrhage, fistulas, aneurysms, so forth. You want to know what the different types of embolic agents. They're usually broken up into a temporary agent, and that's more often than not gel foam, and permanent agents, which are coils, PVA, alcohol, and balloons. Okay, there's other permanent agents. You really don't need to know much beyond this. You want to know what vascular territories are amenable to embolization. In the GI tract, anything proximal to the ligament of Treitz has and traditionally could be embolized by a combination of coils and gel foam. Things distal to the ligament of Treitz sort of historically were not embolized. More currently they are with microcatheters. And then the risks obviously are non-target embolization and ischemia. For duodenal hemorrhage, which this case was, as we said, all upper GI bleeding is initially evaluated and treatment is pursued with endoscopy. They only come to the IR suite when they've failed, typically. The other reason endoscopy is important is because you want to differentiate arterial bleeding, which is treated endoscopically and with embolization, from variceal bleeding, which is going to be treated with a TIPS if they come to the IR suite. For fundal bleeding, you want to do a left gastric artery embolization, irrespective of whether you see bleeding on your own angiogram. If they saw fundal bleeding on an endoscopy, you embolize the left gastric artery. For duodenal bleeding, similarly, you want to do a GDA embolization. The other thing to remember about a GDA embolization is you may have to come up from the superior mesenteric side and embolize that also. Coils plus gel foam pledges are usually what we use. They seem to work pretty well. I would say you don't need any other agents besides gel foam in some patients, but these coiled gel foam sandwiches are very helpful. And then the risk of ischemia is very low because the bowel proximate to the ligament of Treitz has a dual blood supply. So, next case. Classic example of bilateral ostial renal artery stenoses, typically atherosclerotic. Things in the mid portion, you're thinking of FMD and other etiologies, but atherosclerotic disease affects the proximal artery. Okay, it's an aortogram, bilateral ostial renal artery stenosis. Really not much of a differential here, and the treatment is renal stenting. A single fluoroscopic image during the exam, a balloon being dilated across the lesion. You have a sheath in place, a wire across the lesion. There's a balloon expandable stent at the ostium here. This is the follow-up aortogram. You can see good and wide flow, or good rapid flow through both stents which were placed in the renal arteries. So the bare essentials of angioplasty and stenting, many of this John went through. You need to know what medications you give during the procedure. You need to know the basic technical aspects, and the most important thing you have to realize, obviously, is you don't pull the wire back prior to checking the results. And then what lesions respond best to angioplasty. As a general rule, focal lesions in large vessels that have good inflow and outflow are going to respond the best. Okay, Conversely, long segment lesions and small vessels without good inflow and outflow respond horribly. So those lesions are going to be the ones that you're going to want to treat with dilatation. When do you stent? You stent after a poor result, if there's a dissection, or sometimes we primarily stent for things like occlusions that we cross or for certain osteostenoses. Again, to reiterate, osteorenal artery stenosis are usually atherosclerotic. The idea of global ischemia can be applied to this kidney, which basically means that there's bilateral renal artery stenoses or a single kidney with a renal artery stenosis. That's an indication for percutaneous treatment. As a general rule, for osteal lesions, PTA alone is ineffective. It can be used and is used by itself for mid and distal renal artery lesions, but not for osteal lesions. The osteal lesions are almost always stented. You also need to know what you stent and why. For hypertension, typically if it's caused by atherosclerotic disease, you can expect about a 15% cure rate. Most patients will improve, but about 30% will have no response. Okay, the cure rate and the improvement rate is much better for FMD than it is for hypertension caused by atherosclerosis. In terms of treatment for renal insufficiency, very easy to remember. A third of them are going to get better. A third of them are going to stabilize, which is actually an improvement because most of these patients have declining renal function, and a third are going to continue to worsen. Next case. So what do we have? We have a runoff of the leg. You see intraluminal filling defect extending down throughout the distal superficial femoral artery into the popliteal artery, occlusion of all three trifurcation vessels. So this is a thrombus. This patient was a man who has antiphospholipid syndrome, and he stopped taking his Coumadin and thrombosis and presented to the ER with a cold leg. So, leg arteriogram, popliteal artery occlusion, no well-developed collaterals, embolus versus thrombosis. Okay, and this turned out to be actually a thrombosis. And the workup and treatment is either thrombectomy or thrombolysis. This was a subsequent angiogram after we did thrombolysis, and you can see we've restored flow through all these vessels, and they have good flow down through the trifurcation vessels. The bare essentials of thrombolysis. First of all, when I was a resident, all we had was urokinase. About 2 or 3 years ago, all we had was TPA. Now we have both again. Both are back on the market. In point of fact, TPA is probably what's used by most hospitals currently and will continue to be used primarily because of cost reasons. Urokinase, although it has been approved to be back on the market, is far more expensive, and now that people have experience with TPA, that's generally what's used. You need to know the contraindications of thrombolysis, obviously any intracranial pathology, any active bleeding, infection, and the most important one that most people always forget is a non-viable limb. What's a non-viable limb? That's a limb that has no motor or sensory function, okay? Most of these patients will not ever be referred to you because they're usually triaged by someone who realizes it's a non-viable limb and they never come to the IR suite. Your goal of thrombolysis is to reestablish the baseline condition, okay? That usually isn't very good, or they would not have thrombosed. So you almost always have to do some further intervention after you've reestablished flow, whether that be a surgical bypass, whether that be angioplasty, whether that be correcting the coagulopathy. But all you're going to try to do is reestablish the baseline. Complications include bleeding, whether that's local or remote, and pseudoaneurysms. And again, similar to angioplasty, your best cases are those that have short acute clot, good inflow, outflow. Short lesions, big vessels. Okay, those do the best for percutaneous treatment. As a general rule, we use a contralateral approach simply because we don't want to impinge on the inflow in the vessel we're interested in, and also we don't want to interfere with any surgical options the patient may have. You can use either an end hole or an infusion catheter. For longer clots, most people use some type of infusion catheter, although the data is a little bit scarce whether or not you really need to do that. Infusion catheters are more expensive, but they're also funner to play with, so a lot of people like those. If you're going to remember one dose, just remember TPA at 1 milligram an hour. In point of fact, most people have gone down to lower and lower doses with TPA. A 0.5 milligram an hour is probably a little more accurate, and some people go down to even 0.1 milligram per hour. But if you want to remember one number, 1 milligram an hour is generally what you can use for most lesions, whether they be arterial or venous. And again, I want to stress you have to treat the underlying problem after successful treatment, and whether that be with PTA, with surgery, or anticoagulation. You need to address the problem. You're not done after you lyse the clot. This is probably becoming for maybe historical interest only, but it's a pulmonary arteriogram, clot, a lot of clot here. So pulmonary arteriogram, central intraluminal filling defects, really not much of a differential. And the workup is either thrombolysis, which is actually one of the only on-label indications for urokinase, or anticoagulation, and more commonly filter placement. What do we see here? We see a static view. There's a ruler over the spine that gives you a pretty good indication that they're putting in a filter if it's a venous study, and you can see a Simon-Nightingale filter. In point of fact, pulmonary arteriography is a very good, safe test, particularly with digital subtraction angiography and non-ionic contrast agents. Most textbooks will quote a very high morbidity and mortality rate, upwards of 1, 2, 3, 4% for pulmonary arteriography. This is just completely wrong in the year 2000. The largest series is actually out of Duke. They had over 1,000 without any deaths. And why is that? The main reason patients died early on was you gave them a large osmotic contrast load in a patient that had either right heart strain or right ventricular failure. And the large osmotic load that you injected over a rapid period of time caused patients to go into acute right heart failure. That just doesn't happen anymore with our ability to inject non-ionic contrast agents or isoosmolar contrast agents, and to monitor the pulmonary pressures before we give anything. Okay, so you get access to the pulmonary artery. You want to take a pulmonary artery pressure measurement. There's a variety of catheters you can use. We usually use Van Ammen's or Grolman catheters. And then there's certain findings of acute versus chronic emboli. Chronic emboli tend to be more widespread. You see evidence of recanalization. And then you want to know about the indications for thrombolysis. In terms of filters, the indication is either a failure or contraindication to anticoagulation. Filters are second-line treatment. The size considerations are important. This used to be a very simple cut and dry thing, but now there's a variety of filters on the market, and these numbers are sort of not as easy to remember. If you have to remember any number, just remember if it's less than 28 millimeters, you can put in practically any filter. If it's between 28 and 40 millimeters, you want to use a bird's nest filter, and if it's above 40 millimeters, the cable diameter, you want to either use, probably most often, bilateral iliac vein filters. And then you want to look for variants. Commonly in Louisville, they talk about you'll get cases of circumaortic left renal veins where you want to put the filter below the lowest portion of the circumaortic vein, or a dual cava where you need to put filters in both cavas. Going to the next case, these are 4 images from a TIPS procedure. Okay, the first image, you can see a catheter coming down. You've catheterized the right hepatic artery and done an injection, and you're refluxing a little bit of contrast into the portal vein. The second image, you've actually punctured through the liver parenchyma and you're doing a direct portal venogram. The third image, you're dilating the tract. Usually the waist is at the entry point of the vein. You'll see this waist in both the portal vein and the hepatic vein. And finally, a stent's placed across that tract. Typically, these days we use a covered stent. This is an older case where we used a wall stent. So the study is a transjugular intrahepatic portosystemic shunt, or a TIPS procedure. The findings are those punctures. There's no differential. And the workup and treatment, these are done for variceal bleeding unresponsive to endoscopic therapy or ascites unresponsive to medical therapy. The bare essentials of a TIPS. What are the contraindications? Really, the only absolute contraindication is right heart failure. Okay, you can't unload the portal vein into the right heart if you're in right heart failure because the patient will die. Everything else is a relative indication. Encephalopathy, if it can be treated. Sepsis, if it can be treated. Polycystic liver disease, people have called that into question. An acceptable post-stent gradient is less than 10. And like I said, covered stents are used more and more commonly. In fact, there's a lot of data emerging from Zeev Haskell's study that shows these covered stents have much longer patency rates and should be used primarily now. So the complications of TIPS, encephalopathy develops in a quarter. The vast majority of those patients are able to be treated with lactulose and dietary restrictions and neomycin, so that you can treat almost all of them and get this number down to about 5% that are refractory. The mortality is 5%. That's a tricky number to know, because the mortality of the TIPS procedure, maybe the sort of procedural mortality should be less than 5%, but depending on what stage liver disease the patients are, if you're doing this in patients that have like our Child-Pugh C liver patients, their mortality at 30 days are going to be upwards of 20 to 30%. So it really depends on the group that you're doing the TIPS in. And then What we found and what we learned early on is with the bare stents, there's a 75% restenosis rate, and these all will restenose and occlude over time. So that's why people have gone now to covered stents, which seem to have really resulted in much better long-term patency. So here's a cartoon of a TIPS procedure, right hepatic vein, portal vein, blood goes in, blood goes out. Okay, cirrhotic liver, you get this roadblock here of the liver. You develop varices. The blood needs to find another road back to the heart. You have ascites that go out via the Starling equation. So what is a TIPS? A TIPS is just a connection from the portal vein to the hepatic vein. So you're bypassing this roadblock and you're decompressing these varices. Again, a wedged hepatic venogram, portal venogram after you've punctured through the liver into the portal vein, dilatation of the tract, and finally stent placement across that tract. There's a next case, not projecting very well, but the abnormality in this case is a plain film of the pelvis, and you can see this central venous catheter, which is a little bit atypical in location. This was placed during a code. It is coming up far above the femoral head. These should be entering about here and going up and taking a strange course. So this patient, they were concerned about this catheter placement, although they were drawing blood off of it. So we did a CT exam, and you can see there's frank hemorrhage throughout the pelvis, and this catheter, which is entering about the level of the umbilicus, it looks like to me, and entering in one of these iliac vessels. So patient is then referred to angiography for further evaluation. This is a direct injection into the central venous catheter, and you can see it's been directly inserted into the left external iliac vein. You can imagine at this point you just can't pull this catheter out because there's no way to compress this area. So we decided to treat this percutaneously. So what we did was we came up from one side, we put an occlusion balloon here to stop the arterial flow. We pulled out the catheter over a guide wire, so we had an ability to go back in and close the hole if we absolutely needed to. Got access from this side, came up and put a covered stent across the rent. This was the initial angiogram shot through the up and over sheath, and you can see we actually haven't completely sealed the hole yet because blood is still leaking out along this guide wire, which was the original tract. We further dilated the balloon, dilated the covered stent with a balloon, and then we're able to cover the hole. Okay, so now that we have covered stents, it really expands our ability to treat some of these injuries. So, an intra-arterial central venous catheter. Remember, you have to put these things in below the inguinal ligament, right around the femoral head, and that's basically because that's your ability to control bleeding when you get it out. In this case, arterial injuries are more and more commonly being treated with these covered stents. Okay, next case. This is a up and over venogram, and what you can see is some type of stenosis or occlusion of the left common iliac vein with drainage via cross-pelvic collaterals and up a vertical vein. The differential in this case would include a DVT, would include May-Thurner, extensive lymphadenopathy, or some type of mass. So again, a venogram, occlusion of left common iliac vein, DVT, May-Thurner, as we said. And the workup and treatment would be either thrombolysis or stent insertion. In point of fact, this was a chronic finding in this patient. We knew it was not an acute DVT. So what we did was crossed it and put a stent across here and had a nice hemodynamic result. You're still seeing a little bit filling of that vertical vein, but we've opened this up. Now there's antegrade drainage. Typically, most of these patients will come in with left leg swelling after use. So this is a CT from the same patient. This is actually how it was diagnosed. You can see here that this is the left common iliac vein, and it's being compressed by the right common iliac artery as it crosses between that and the spine. And that is what May-Thurner is. So what is it? It's an extrinsic compression. The repetitive trauma, it's another one of these compressive syndromes that I was talking about earlier. And the repetitive trauma leads to either thrombosis of the vein or some type of a band or spur that forms. Okay, it's thought to be why left-sided DVTs are much more common than right-sided DVTs. And typically, most of these patients these days are treated with self-expanding stents. So what's happening on this view, here's that same venogram, and you're seeing this artery compressing this vein right here. So it's a compressive arterial variant. There's another example with a patient that had actually developed a DVT and thrombosis of this area, was lysed and stented. Good results. And that's it. Thanks.
Well, we're going to be talking about calcifications, and we're calling it Calcificology 101. First question, why are calcifications important? Well, calcifications really provide for us the only reliable radiographic sign we have of non-invasive breast cancer. So they are absolutely essential for this very early, treatable, and most of the time curable disease. Most breast calcifications are going to be associated with benign disease. So we have a responsibility to be able to differentiate as best we can between those that are suspicious and those that are almost certainly benign. Also, understanding calcifications helps us understand what the pathologist is going through and what the pathologist is saying, and actually may provide a clue to the radiological pathological correlation or recognizing discordance, and we'll see examples. Calcification of malignant classification of malignant calcifications also is going to help influence management decisions. So, breast calcifications are associated with benign disease. Then our job is to take all of these calcifications that we recognize and triage them in some way so that we can separate those who need to go back to screening, in other words, those that are classically benign, from those that need to return for some additional workup, or ultimately those that are going to go on and have an open biopsy or needle biopsy. We're really not too concerned about the chemical makeup of calcifications because we can't make that distinction radiographically, but as a general rule, calcium oxalate is the type of calcium that is most often associated with benign disease, particularly milk of calcium. Calcium phosphate is the principal component of the calcifications that we see with malignant calcifications, but they can also be associated with some benign calcifications. Now, where do calcifications form when we see them in the breast? We know we can get calcifications forming in the skin or within the stroma, meaning the supporting structures or the fatty tissues. But the calcifications we'll discover that are really important for us are the calcifications that form within the ductal system. Skin calcifications and stromal calcifications can be misleading at times and make us think that we may be dealing with ductal calcifications. Calcifications also form in association with a number of conditions, necrosing tumors, any kind of dystrophic calcification. Dystrophic is a term that we use to mean developing in dead or dying tissue. Vascular calcifications, foreign bodies, parasites, bone-forming tumors, including metastatic lesions. All of those are examples. Skin calcifications form within the hair follicles. They form within sebaceous cysts, and sometimes within scars that might be burns or lacerations on the skin surface. There are a number of collagen vascular diseases that are associated with skin calcification, such as dermatomyositis, scleroderma, calcinosis universalis, lupus, and so on. Calcifications like this generally don't give us much difficulty. When we see calcifications of this type and pick up the magnifying lens, we recognize these as little donuts or Cheerios, and we know we're dealing with calcifications within hair follicles, giving us those radiolucent centers. We can ascribe those right away to the skin. This is an example of calcifications forming within a sebaceous cyst. Calcifications of this type are linear, but they're really going in the wrong direction. They're not heading toward the nipple as we would expect calcifications within the ductal system to be doing. They're also going to an area of skin thickening. We could postulate that perhaps this lady has some kind of scar. Over a period of time, interestingly enough, the calcifications become increasingly more prominent. This happens to be a patient who has, in fact, had surgery. She had a lumpectomy, and she has had radiation therapy. Patients who have had radiation therapy are prone to develop more dramatic changes or heavier or more extensive calcifications that would form in the way in dying tissue, scar tissue, or anything that's become devascularized. Also foreign bodies, as we'll see in a moment. Stromal calcifications, of course, can be fat necrosis. Any kind of devascularized tissue can become sclerotic and calcify. Vessel walls, of course, will calcify. Calcifications of this type, this coarse, this big, this irregular, are a slam dunk for us. We know we don't have to have a diagnosis here. We know this is benign disease. This is almost certainly a dystrophic type calcification. It could be any number of different conditions. We could inquire about trauma. In this case, the patient has had trauma to her breast, and that's dystrophic calcifications in fat necrosis. When we see radiolucent centers, we're generally quick to ascribe fat necrosis as the explanation. This is a patient who has been operated on and has fat necrosis in both breasts. Again, calcifications in both breasts with some radiolucent centers. If we look at the scarring carefully, we can see telltale signs of probable breast reduction, and it would be reasonable to draw that conclusion. In fact, it is a patient that's had bilateral reductions and developed fat necrosis and dystrophic calcifications. Calcifications can develop in benign masses. We know they form within pseudocapsules around benign masses. They can form within epithelial spaces that may be entrapped within benign masses. And of course, in areas of necrosis, as we've seen, we know that calcifications form within cysts, giving us the milk of calcium type appearance that is very easy to recognize. And of course, the cyst walls themselves will calcify. Calcifications can also develop in the ductal system and be benign. We know that hyperplasia with or without atypia can have calcifications that are indistinguishable from low nuclear grade DCIS, and we'll understand that better in a moment. But let me come back to the benign lesion, and the fibroadenoma is a typical example. The fibroadenomas have around them a pseudocapsule. They also have entrapped within them epithelial elements that we find within the breast itself. All of these areas are potential areas for developing calcifications. Here are calcifications developing within the pseudocapsule around a fibroadenoma. They can become increasingly more extensive until we really have an eggshell appearance, much like we see with fat necrosis. But they can also develop within these entrapped epithelial elements. And when they do, of course, they can begin to look more like ductal calcifications and be more sinister in their appearance and often lead to biopsy. Here that we can see these calcifications forming within these epithelial elements. You can get areas of necrosis or devascularization within the fibroadenoma that ultimately calcify. You can get multiple areas that will eventually coalesce, and when they do coalesce, we get the classic popcorn calcification. Calcifications of this type are generally called oil cysts, but I'm not sure they're all oil cysts. I think many of these actually may be calcified simple cysts. When you see this dense of calcification and this uniform size and no history of any kind of trauma, it's difficult for me to understand why they would really be oil cysts. These are typical oil cysts. Much more radiolucent, much thinner capsule. These we can be quite certain represent oil cysts. You can aspirate oily material from these. Arterial calcifications, of course, can look linear. We're fortunate when we see two walls involved or extensive vascular calcification in the neighborhood and know that this is all part of the same process, but we have to be careful because we can be misled or seduced into thinking that everything we're looking at is just vascular. Arterial calcifications are a consequence of low age. They develop in patients that are diabetic or have renal failure. Any hypercalcemic state and high cholesterol states are the conditions that we see in association with vascular calcifications. A picture like this tells us that there's something wrong with this picture. There's some discordance here. We've got extensive calcifications in a breast that really looks like a very young woman. How can we put it together? Well, she could be postmenopausal on estrogen. I doubt it. That's really too dense for a postmenopausal patient. Could she be young and have vascular calcifications? Yes. She's a diabetic at age 31. Arterial calcifications, as I mentioned just a minute ago, can be very deceptive. When we see calcifications like this, we really have to look carefully. We can't be quite sure at first glance that this represents vascular calcifications. If we conclude that they're not vascular, then they're linear, slightly irregular, and they would have to be biopsied. These were ultimately concluded to be vascular. 2 walls were seen in some of these areas with spot magnification. Calcifications can develop within malignant masses. They can develop within intraductal components that still are present in the area and surrounded by the invasive process. Calcifications can develop within areas of necrosis in the tumor itself. They can also be benign calcifications that have become entrapped by the malignant process. Osseous metaplasia is an uncommon explanation for some of these calcifications. Something like this really is pretty easy to put together. We recognize that we've got a big invasive component and we've also got DCIS. So we can say this is invasive ductal carcinoma with an extensive intraductal component. Here's the microscopic look of an area of necrosis and calcification developing within an invasive carcinoma. Here's an example of benign calcifications that actually predated the development of this patient's invasive cancer. The invasive cancer, of course, is very easy to recognize, but the cancer has just swallowed up the benign calcifications that were in the neighborhood. A rather unusual calcification. This happens to be a foreign body, a calcified Penrose drain that had been left in the breast for a number of years. When we see things like this, we can recognize them quite easily as sutural calcifications. But when you see sutural calcifications that are this conspicuous and this calcified, you can be almost certain that this is a patient who's had radiation therapy. It is very unusual to see sutural calcification in the absence of radiation therapy. Foreign body reactions give us calcifications. We know that the capsules around implants can develop areas of calcification. Again, this is a dystrophic type of calcification within the fibrous capsule. This is a patient who has been explanted and she's got residual calcifications in the remaining capsule that was not removed at the time of her explantation. Parasites calcify. This happens to be cysticercosis. I'm sure you'll be ready for the one that comes down the pike next week and you won't miss it. Now let's look at the calcifications that form within the ductal system, because this is where all of our trouble really begins. This is where the bad stuff happens. And we have to understand how these calcifications form if we're really going to be able to recognize them in the first place and triage them when we're faced with a lot of benign calcifications also. Quickly looking at this macro thick section of terminal ductal lobular unit, we can see the acini, the grapes if you will, on the end of the stem. We can see the extralobular portion of the terminal duct and the intralobular portion of the terminal duct. Here graphically, we can see the ductal system, including the TDLU, all lined by a single layer of cuboidal epithelial cells. That's what the red arrows are pointing to. The A's represent the acini, and the shaded area, the extra portion and intraluminal portion of the terminal duct, extralobular and intralobular portion, excuse me. Now let's look again at the TDLU in a graphic way and see here represented all of the diseases, all the benign diseases that we commonly see in association with the terminal ductal lobular unit. The arrow is pointing to a dilated acinus that has a hyperplastic epithelium that has filled the entire lumen, obliterating the lumen, giving us lobular hyperplasia. When we use the term lobular, we're generally referring to the acinus. When we're talking about ductal, we're generally referring to the intralobular or extralobular portion of the terminal duct. So that is lobular hyperplasia. This acinus represents the formation of a microcyst. Microscopically, we see these dilated acini, and in some we may see the microcalcifications. If you look at it closely, you can see in this case we have obstructed the neck of the acinus so that we can no longer let the fluid out. The fluid is entrapped. It happens to be sclerosing adenosis in this case. It could be a proliferative process that obstructs the lumen. Whatever it is, pinches off the outlet to the acinus. The acinus distends, salts precipitate from the secretions, drop into the dependent portion, and we get milk of calcium. Milk of calcium, as we look at it in a craniocaudal projection, gives us this cotton ball, fluffy little accumulation of groups of microcalcifications. If we look at it with a horizontal beam, we see the calcifications layering in the dependent portion, looking at them on edge, and we see the teacup formation. Here is a thick section micrograph, again one of Tabar's slides, showing the acini, multiple microcysts throughout this entire terminal ductal system. Here we can see particles of calcification, or if you will, milk of calcium within this dilated microcyst. Another cluster of grapes, dilated microcysts. And really that's what they resemble. Any one of these can become distended and progressively dilate as long as there's nothing prohibiting it from dilating until it becomes a macrocyst. In this case, we have sclerosing adenosis that has completely surrounded the acinus so that at this point the acinus can no longer dilate. Its maximum size is defined. The calcifications precipitate, ultimately coalesce, and form a spherical calcification, which is the pearl-like calcification we see with sclerosing adenosis, the typical sclerosing adenosis. But sclerosing adenosis can actually deform the acinus before the calcification forms. If that happens, we're not going to get the perfect sphere. We're going to get a linear calcification. And in this case, you can see the linear calcification trapped within this deformed acinus. So again, graphically, the terminal ductal lobular unit made up of acini, made up of the intralobular portion of the terminal duct and the extralobular portion of the terminal duct. It is the intralobular portion of the terminal duct and the extralobular portion of the terminal duct in which all ductal carcinoma originates. Lobular carcinoma is going to originate in the acinus. Now, the term DCIS really implies containment of the cancer cells. The cancer cells are contained by the basement membrane. As soon as the basement membrane is disrupted and cancer cells can get out of this containment, the process of invasion has started. There are synonyms that are used, and we should be familiar with them. A non-invasive breast cancer means exactly the same thing. Intraductal means exactly the same thing, again implying that the basement membrane is intact. And ductal carcinoma in situ, of course, or DCIS, all synonyms that we use for the same disease. There are subtypes of DCIS that are important for us as radiologists to appreciate. The correct and politically correct terminology, I guess, of the day is refers to the nuclear grade of the disease. So we refer to low nuclear grade DCIS. We used to call these small cell carcinomas or non-comitocarcinomas. They have two principal patterns, cribriform pattern or micropapillary pattern. There's an intermediate grade that is a cribriform or micropapillary pattern that's associated with some necrosis, or a solid pattern. And finally, the high nuclear grade disease, which is always associated with central necrosis. We used to call this large cell or comito. Tumor grade is really an expression of the aggressiveness of the tumor. So low nuclear grade would be less aggressive, high nuclear grade, the more aggressive. So again, how does DCIS present itself? Radiographically detected microcalcifications, again, the only reliable sign that we've got, in over 85% of the cases, that's the way that's the way DCIS presents itself. The remaining 15% made up of radiographic masses by themselves, or clinically detected masses, or nipple discharge, and Paget's disease. Well, by now, someone is thinking, why do we even need to bother about this differentiation from low nuclear grade to high nuclear grade if it's all going to come out anyway? Well, there are reasons. In the first place, it helps us and it influences our decisions regarding follow-up, and we'll see why in a moment. It helps us significantly anticipate or estimate the extent of the disease. We'll understand that in a moment. It helps us also in being able to make a radiographic pathological correlation and determine whether or not there is or is not concordance. Okay, let's look at low nuclear grade DCIS. This is a slow, methodical, progressive process. It begins with an area of normal epithelium, single layer of cuboidal epithelial cells that suddenly start to proliferate. And again, we're not talking about DCIS, we're talking about the predecessors that lead us to DCIS. We begin with the normal epithelium, and then we begin this proliferative process. The proliferative process takes one of two forms. It either takes on a cribriform pattern, meaning window-like spaces, or a micropapillary pattern, and you can see the micropapillae there. The cribriform spaces are the spaces in which calcifications will form, either in just hyperplasia, as we're seeing here, atypical hyperplasia, or even DCIS of the low nuclear grade type. It is in these cribriform spaces, so you can envision right away we're dealing with small punctate calcifications. If we move up the ladder, going from hyperplasia to atypical hyperplasia, what we recognize is the presence of a lot of extra mitotic activity. We don't recognize it, the pathologist recognizes it, but lots of mitotic activity. And again, two principal patterns, cribriform or micropapillary. There may be a mixed pattern. Again, the same cribriform spaces, and in those cribriform spaces, we get the same kinds of calcifications forming. There's another little guy in here that we haven't mentioned yet, and that's these little red guys, the myoepithelial cells. The myoepithelial cells are the cells that give the duct its contractility. These are cells interposed loosely between the layer of cuboidal cells and the basement membrane. These are very important to us. Notice that they're present in a normal duct. Notice that they're present in hyperplasia, and they're present in atypical hyperplasia. Well, now let's move up the ladder. Now we've got not atypical hyperplasia, but we have frank DCIS with the same kinds of calcifications, all of which represent castings of these little cribriform spaces. But there's something different. Now, all of a sudden, no myoepithelial cells. Where do they go? Nobody knows. They just pack up and leave. Here are some cribriform patterns of DCIS, microscopic examples. And in this one little cribriform space, you can see three little blue fragments of a calcification that was shattered by the microtome. Another example of cribriform low nuclear grade DCIS, no myoepithelial cells. Another example of cribriform DCIS with calcifications. There are the calcifications, fragmented again. Now, making the distinction between DCIS and atypical hyperplasia, how is that done? Well, here's the official word. There's no consensus presently on the criteria which should be adopted or how they should be applied for the distinction between hyperplasia, atypical hyperplasia, and carcinoma in situ. Isn't that helpful? Who said that? Paul Peter Rosen in his book, Rosen's Breast Pathology, as recently as 2001. what we're saying here is that even the pathologists have difficulty from time to time. So it's not unusual for us to see differing opinions and perhaps some disparity or some conflict with our radiological pathological correlation. Now, just to add a little confusion, we can't keep it entirely simple. Here's an example of cribriform DCIS, not with an absent myoepithelial cell layer, but a hyperplastic myoepithelial cell layer. And it's been postulated that these myoepithelial cells, particularly in this form, this hyperplastic form, may offer some protection against invasion. If that's the case, isn't it interesting that we have hyperplasia, atypical hyperplasia, and then we have DCIS with no myoepithelial cells, and then we go on to invasion? Is it possible that as long as myoepithelial cells are there, we do not have the potential for invasion? It may explain why some low-grade forms of DCIS never become invasive. Again, it's speculation. Quick reference to the intermediate grade DCIS. Intermediate DCIS is the same pattern of either cribriform or micropapillary hyperplasia, but in association with necrosis, necrotic material that becomes entrapped inside the lumen. That's the intermediate grade. That ultimately will calcify. Here's an example of a solid form of intermediate DCIS where the lumen is entirely obliterated by cells, no cribriform spaces left, and you see some necrotic material ultimately calcifying. That too would be classified as an intermediate grade. Now I want to focus on the high nuclear grade DCIS because this is the one we really have to worry about and know about. This is a killer cancer. It is always associated with necrosis. It's a very rapid process. The cells are proliferating rapidly, larger cells. They're dying, sloughing to the lumen, becoming entrapped with secretions. And it is this central area of necrotic stuff that ultimately calcifies. And right away, you can see there's going to be a significant difference between the calcification of this high-grade DCIS and the calcifications we saw in the low nuclear grade pattern. A microscopic look of the necrotic material that ultimately will calcify. Another example of necrotic material and the area that is calcifying within the duct. The evolution of high nuclear grade DCIS is quite unlike that of low nuclear grade DCIS. It is a rapid progressive process. You go from normal epithelium to de novo high nuclear grade DCIS with its associated central necrotic material. Well, by now you've recognized that DCIS is a pretty heterogeneous disease, but it's a heterogeneous disease clinically, mammographically, histologically, and biologically, or prognostically. Here's an example of DCIS with no calcifications. I would predict that this is a small invasive cancer. It was just pure DCIS. Another example of a nodule with no calcifications, a case recently given me by Jan Patterson. I'd never think of DCIS. I would think of a cyst, a fibroadenoma, could be a malignant tumor, invasive disease, but I'd never think of DCIS. It's pure low nuclear grade DCIS. A young woman in her 30s with a small, dense left breast, always been that way, has not changed. Ultimately got biopsied and proved to be a mixture of low nuclear grade DCIS and high nuclear grade DCIS. There's not a single calcification to be seen, and there were no calcifications found microscopically. She went on to nodal sampling because of her extensive disease. No evidence of spread to the lymph nodes. All pure DCIS, no calcifications. What are you to do? What are you to do? Good news and bad news. There's good news and bad news about both the high nuclear grade and the low nuclear grade. Low nuclear grade DCIS, the good news is it's a slow growing process, and some of these may never invade. The problem is we don't know how to differentiate those that will from those that won't. The bad news is that only 50% of the time is it going to calcify. Now you can see that if you had a pure micropapillary pattern, you don't have those cribriform spaces and no place for those calcifications to form. So the calcifications we see do not represent the extent of the disease. More often than not, it's going to be more extensive than what we see. High nuclear grade DCIS has wonderful news. 54% or 94% of the time, it does calcify. So the calcifications we see are a pretty reliable predictor of the extent of the disease. The bad news, it's killer cancer, it's highly aggressive, it's an obligate invader, and we don't have much time. We cannot afford to miss this disease. So which calcifications to work up, which ones to biopsy? That is the question. Ductal calcifications of DCIS are within the duct. Thus, there's going to be a tendency for those calcifications to be lined in a ductal orientation. Calcifications within the acini or walls of the duct are not related to DCIS. They're related to benign conditions. Well, we asked this question. It's going to we need to make the distinction to influence our decisions regarding follow-up, estimating the extent of the disease, and to help us in radiological pathological correlation. Now, I'd like to give you some take-home key characteristics of microcalcifications. If I were to give you only one word for high nuclear grade DCIS, it would be linear. Now, there are other words that we'll use, but linear calcification is the calcification that worries me the moment I see it. The key characteristic of low nuclear grade DCIS is punctate, dot-like calcifications. High nuclear grade, linear, can also be coarse or irregular or pleomorphic, crushed stone, as Tabar likes to call them, branching. Variability in density, very characteristic of DCIS calcifications, and ductal orientation. Remember, they're forming within the ductal system. So what do we have? Linear, ductally oriented calcifications. This is going to be high nuclear grade with a high level of confidence, and we'll be wrong very, very rarely. Another example of linear, high nuclear grade calcification, some branching, pleomorphism, ductal orientation. Rod-like calcifications, always put DCIS at the top of your list until you have gone through the differential and worked them up. Could it be micropapillary or cribriform with necrosis? Yes, because it is the necrotic stuff that gives us the linear calcifications, so that might be an intermediate grade. Secretory calcifications, of course, vascular calcifications, sclerosing adenosis with a deformed acini can give us linear calcifications. We can see linear calcifications in fibroadenomas and dystrophic calcifications. The punctate low nuclear grade calcifications are also round or dot-like, single or multiple clusters. A slight variability in size and shape is common, but again, variability in density and ductal orientation. What have I got? Low nuclear grade DCIS, punctate, clustered, ductally oriented, variable density. Early detection depends on high sensitivity and very good specificity. How do we get sensitivity? We get sensitivity by being disciplined, systematic in our approach, and using optical magnification. How do we get the specificity? We get it by analyzing calcifications with the benefit of radiographic magnification, spot magnification. You find it with optical magnification, you analyze it with radiographic spot magnification. So what have I got here? I've got microcalcifications. They're linear, they're ductally oriented, but I see a shadow accompanying them. Could this be vascular? There was a lot of debate about this. It was finally concluded that these were in fact vascular. What about this? What kind of calcifications have I got? Pleomorphic calcifications, but look at the linear forms and the ductal orientation. What is it? High nuclear grade DCIS. What have I got? Pleomorphism. What have I got? Pleomorphism, different shapes. Look at it with radiographic magnification, linear forms as well. Going to be high-grade DCIS almost for sure. Punctate calcifications, but look at the variability in density. No one should think about sclerosing adenosis with this kind of a pattern. Multiple clusters, but I've got variable size, slight pleomorphism, a little variability in density. These are multifocal. This is multifocal low nuclear grade DCIS. There is a form of DCIS that Tabar coined the term snakeskin DCIS. This happens to be a case of Margaret Reichels from Wiesbaden, Germany. Here's a junior variety. This is not a branching calcifications. These are many, many tiny punctate calcifications lining up inside the duct, tightly packed inside the duct. Calcifications of this type, what would you say? There's the magnification. Would you follow it? Would you biopsy it? Here it is 27 months later. It hasn't really changed much, has it? Would you biopsy it? There she is 7 months later. Brand new calcifications, and the other calcifications are becoming a little bit more numerous. This is high nuclear grade DCIS with an invasive component, or it's an invasive disease with an extensive intraductal component. And this is the consequence of a short delay with high nuclear grade DCIS. I can't really criticize the decision to follow those calcifications, but I think we need to go back and we need to ask ourselves, what would we do the next time around? I don't know, I might do the same thing. But look at those. That's how we learn. Go back to those originals and say, well, you know, there are some linear forms there. There's a remote chance that that could be introductory. I really think these are benign, but there's a remote chance that those are linear calcifications. What should we do about it in that circumstance? All right, here's a case. Time's up. Are you going to call it a BI-RADS 1, 2, or 0? Did you see that? Do you still see it? That's optical magnification. Let's work it up. Analyze it. Now, are you going to worry about it? Sure. I've got some pleomorphic calcifications. I've got some variability in density and size. And I also have all of this going on in a little cloud. It's got to be biopsied. Is it benign or malignant? The answer is yes, of course it is. So biopsy it. High-grade DCIS. Did you see it the first time around? Calcifications, we see some masqueraders. You have to beware of masqueraders. You think everybody that you're looking at is the same, but there just might be an infiltrator. There are a lot of lookalikes. Ductal hyperplasia with or without atypia can give us calcifications. Remember, the epithelial or the cribriform spaces, sclerosing adenosis, fibroadenomas and papillomas and vascular disease, dystrophic calcifications, fat necrosis, artifacts, foreign bodies, all of these things can give us those kinds of calcifications. Remember the hyperplasia and atypical hyperplasia? Same kinds of calcifications that we get over on this end of the spectrum, which is DCIS. What is that going to be? It is going to be low nuclear grade DCIS until proven otherwise. It's benign ductal hyperplasia. Should I be surprised? No, because the same kind of calcifications in hyperplasia or atypical hyperplasia are the kinds of calcifications that we see lining up in a duct in this fashion. So I cannot tell you whether this is hyperplasia, atypical hyperplasia, or DCIS. I will tell you that if it's DCIS, it's low nuclear grade. I will not buy sclerosing adenosis because these are ductally oriented. I will not buy high nuclear grade DCIS. What have I got? Pleomorphic microcalcifications, maybe some ductal orientation, can't be sure. Some variability in density, it's a fibroadenoma. Do I have to apologize for biopsying that? No, because these are the kinds of calcifications forming in these epithelial spaces. What about this one? Variable density, variable size, Little nodular feature, maybe, maybe not. Are you going to watch it? I'm not. It's sclerosing adenosis. Do I have to apologize? No. Isn't there a little linear form down there? Yeah. Where did that come from? Well, it came from that deformed acinus. Now, that's not too difficult. When we see a snowstorm like that, we can be absolutely confident we're dealing with sclerosing adenosis. These are uniform high density, uniform density, as well as uniform size and shape. What about this? This is 18 months after lumpectomy for focal DCIS, and this is developing in the site of the lumpectomy. Pleomorphic calcifications, multiple variable density. Could that be DCIS? Absolutely. What would be very unusual is to see a recurrence this soon, after 18 months. The diagnosis is fat necrosis. Do I have to apologize? No. I can't take a risk, even though it's unusual to get a recurrence in 18 months. Vascular calcifications resembling ductal calcifications. You want to hope that you don't end up biopsying something like this. You need to work them up very carefully. This is easy for us, the smooth linear branching calcifications that are calcifications forming in a duct that is lined by a single layer of epithelial cells. This is plasma cell mastitis or secretory type calcifications due to periductal or ductal wall inflammation. Calcifications can develop within papillomas and be indistinguishable from DCIS. I might even throw a fibroadenoma into it, obviously not when I see it right at the end of an obstructed duct on a ductogram, but papillomas can give us appearances that are identical. When do I suspect artifacts that masquerade as calcifications? When I see them only in one view, when the skin appears to be involved, if it's in the axilla or if it's in the inframammary fold, and if they appear more dense than usual calcifications, and if they have an atypical distribution. That's the time when I begin to wonder if I'm possibly dealing with something artifactual. So again, which ones am I going to biopsy? The answer is none of these is going to get biopsied until we've evaluated with spot magnification, thoroughly characterizing it, determining the extent of the disease. And when we say spot magnification and workup, we mean making that analysis that helps us triage. I will go to benign, high probability, or suspicious, or perhaps even after all of this, I'm still in limbo and I consider it to be an indeterminate group. If it's benign, I know it's going to go back to screening. If it has a very high probability of being benign, it's going to go to 1-year follow-up. If it's suspicious, or if I still can't be confident that it's benign, then it's going to get biopsy. All of our workups are done with spot magnification. I think that's an absolutely essential element in the workup of microcalcifications. Vascular calcifications, right? Typical vascular calcifications. Be careful. Here is a change of angle. Did you see him? Right there. Right along the vascular calcification. Sonography for calcifications. Here's a group of microcalcifications that I'd put in a somewhat indeterminate group. I'm not quite sure what they are. Why would anyone in the world think of ultrasound when there is no mass? Because there is often a mass that you don't see. When I have a group of microcalcifications like that, I think ultrasound is a wonderful tool. You'll either represent an invasive component of DCIS, or you may recognize a big distended duct filled with DCIS. So, which ones to biopsy? Evaluate them, work them up, analyze them. What have I got? Pleomorphic calcifications, linear orientation, biopsy, slam dunk case. What have I got here when I work it up? I've got variable density punctate calcifications with ductal orientation. I'm going to biopsy it. What have I got here? A cluster with variable size, slightly irregular shape, but variability in density. I'm going to biopsy it, perhaps, almost certainly. What about these? Uniform, high density. No, never, ever. What about these? Uniform, high density, loosely scattered. No, don't biopsy it. What about this group? Well, clustered, variable density, variable size, slightly variability in shape. I'm going to, well, probably. I'm going to biopsy those. Can I be more definitive than that? No, because I go back and it depends on what I had for breakfast. They might get followed, they might get biopsied. Who knows? Surveillance or biopsy. If it's a high probability that I'm dealing with something benign, but there's a very, very remote chance it's low nuclear grade DCIs, I don't feel bad about following these because I know I'm dealing with, at the worst case scenario, a very slow process. If I see something that's probably benign, but there's a remote chance that it might be high nuclear grade, I'm going to biopsy it. I'm not going to give it a second chance at all. Please remember, if you're disciplined, if you're systematic in your search for subtle calcifications, and you're thorough in your workup, things can still go wrong. Experience is not a substitute for attention to detail. Thank you very much. Okay, we're going to just show some interesting cases, and these are cases that I hope you'll find interesting, but also cases that should stimulate you to start thinking and perhaps ask some questions. I'm going to begin by talking about a couple of examples of an area of the breast that is very important that we seldom we seldom get away in our practices from making a mistake in this area. I doubt if there's anybody in here who reads a lot of mammography that hasn't looked back and made a mistake in this particular area of the breast. And this is an area that I think we should all be very aware of, because the apical breast is that axillary extension of tissue toward the axilla, and we like to see symmetry, and of course we like to evaluate anything that looks atypical or out of the ordinary, but we tend to pass this area off very easily, and we sometimes don't appreciate interval changes or asymmetric changes. And this is an area that I think is really entitled to the designation of the tip of the iceberg. I don't think there's anybody in here that would be concerned about the appearance of this image. Are you worried about anything that you see?
Not at all.
Mike has not seen anything yet, so you're in good shape.
Isn't that a mammogram? I'm worried about it.
Okay. All right. Here she is in December of 97, gone from 296 to 1297. Are you worried about this area? Would you be worried about this area?
Maybe.
Maybe. Okay?
No.
Well, if you saw this and it looked exactly the same on the other side, and I'm sorry I don't have an image of the other side, I doubt if you would be concerned. Well, somebody certainly was not concerned. That's December 1997. Here it is in September of 1998. Would you be concerned? How many would not be concerned? You wouldn't raise your hand if you weren't, would you? What do you have to say about that?
Well, it's definitely a spiculated or a structure. It looks like it's at least architectural distortion, perhaps even a mass. There's been coalescence of the tissue there. Looks almost like there's the tip of a mass sticking out.
Yes. But isn't it interesting? There she is in February 1999.
Okay. Well, actually, it still has a spiculated margin. There's even more density, but it's less well defined as a mass.
It's less well defined as a mass, but it was immediately recognized by the radiologist. Why?
Just looks so different from the other side.
No.
Palpable.
Yes, it's palpable. And the palpability makes things much more perceptible. And I don't think any of us can say enough about the value of going in and putting your hands on something that you think looks a little out of the ordinary. Well, there it is in 95, there it is in 97. Now, looking at those two alone, can anyone honestly say there's no significant interval change? You can't say that. You can't say unequivocally there's a dramatic change, but I think you have enough information at this point to get the spot magnification device out and to press it out or palpate it or put the transducer on it. Putting the transducer on it and palpating it takes, 29 seconds? And chances are very good that one of those things would have raised the level of concern sufficiently to lead to biopsy in December 1997. Now, of course, here, it's actually referred to as no interval change. And what to me is fascinating is that it is a very suspicious looking mass here, and look at it 4 months later, 5 months later, it's actually not as obvious. But it was quickly recognized by the very same radiologist because it was palpable. Did you learn a lesson? Oh, huh? Okay, how about this case? What do you think of that, Mike?
Don't see much of the pectoralis muscle on the right. Not as much as far as the depth as on the other side. There's some lymph nodes up in the axilla on the left. That doesn't look too bad.
Doesn't look too bad.
No.
Okay. There she is a year later.
Well, it's a little more dense over the pectoralis on the left. And I don't know if that's artifact up in the most upper portion of that.
Probably, yeah.
Okay. It's just this vague density, sort of underlying on the pectoralis muscle.
Pointer. Yeah, it should be there. Here?
Yeah, somewhere there. The whole area is much more dense. It wasn't there before.
Well, let's go back.
Yeah, it really wasn't there at all before. Pretty vague, but it's definitely a change.
So what would you do?
Probably want to compress it, work it up, see if there's a real finding or not.
So spot compression.
Absolutely.
And if you weren't sure?
Still do an ultrasound, most likely.
And when you do ultrasound, you know your fingers are going to go on.
Absolutely.
All right, there it is in September 1998. And here it is in January 2001. So it's a little over a year. And Mike has said that there's an interval change sufficient to work this up. He can't be definitive about it. This is where glandular tissue lives. And in fact, if you use your magnifying lens and a little wiffle dust and imagination, there is some smoke here, which is very typical of axillary glandular tissue. And I would blow it off as just benign glandular tissue. I would certainly not have called anything abnormal at that stage. But there's an interval change. Now, of course, in December of 2001, look what we've got.
We've got the ever-present BB indicating that it is palpable at this point.
And it
most
hasn't
likely.
changed that dramatically.
Not dramatically, no.
But again, recognized immediately by the same radiologist because it's now palpable. Well, what can we extract from this thing? I think that the things that make it very suspicious, things that Mike has already mentioned, but notice that there are margins now that were not there before, in addition to the increased density. When you get margins and density developing, you've got to have a high index of suspicion. It's a 3 centimeter high-grade invasive carcinoma with 23 nodes, 12 of which were palpable. So even at that stage, I think, had we been making a careful comparison, we should recognize that there's asymmetry and there is a strong suggestion that there has been interval change, and we deserve to work it up. And the workup, again, is spot compression films, ultrasound, and palpation. How about August 98? Apical portion of the breast. Anything that bothers you?
Not really. Few little nodular densities, but they don't really have much of a scary appearance at this point.
I think most of us would pass that off most of the time. I'm always my eye is always grabbed when I see a spiculation like this, which, only witches wear pointy hats, and makes me wonder what's going on. Well, there it is in January of '01.
Well, now it's got lots of pointy hats in many directions. So it's
and converging lines.
Converging.
Yeah. The report says area of asymmetry in the left upper MLO seen better than in 1998, but is believed unchanged. Seen better. There it is in January '02.
Definitely seen better.
Common sense should tell you that seeing better might just mean there's been a change. And if you see something dramatically better, always ask that question. Is it possible that this has actually changed? Use all the available information you've got. Now, what have I got here?
Got a BB on the film. So again, the most likely indication for that being there is that there's a palpable lump. Again, nothing.
Vague fullness in the lower axillary region.
That's the clinical.
That's the clinical.
So again, there's some vague density seen again under the pectoralis muscle.
If there was no BB and no history, would you be inclined to just blow it off as accessory glandular tissue?
Most likely.
It's classic, typical accessory glandular tissue. There's the spot compression film. Looks like, acts like, walks like, talks like axillary glandular tissue, except it's a new clinical finding, and it's an invasive lobular carcinoma.
Well, here's the history on this patient. She's 45 years old. She presents with a bloody nipple discharge. And what would we do with any patient who has a spontaneous bloody nipple discharge on one side?
Well, I would try to identify the offending duct and make sure that it's coming from a solitary duct.
How might you do that?
I might examine her.
Well, that'd be good. Okay, and you found that everything is as you suspected?
Then I would do a ductogram.
Okay. So that's what was done. Ductogram was performed. Here's the ductogram. And this was the correct duct because after we cannulated it and evaluated it, I always expressed the fluid from that duct, and it came out as a mixture of contrast and blood. So it was clearly the correct duct.
Well, I don't see anything definite. I think this just may be an overlapping duct right here.
It was.
But other than that, I see a few areas of slight ectasia, but no interluminal defect. No definite interluminal defect.
Right, and it was essentially a normal ductogram. But in the process of doing that, I always get these ductograms with magnification. And I always look around at the rest of the breast in the area, of course. And do you see anything there that looks at all suspicious?
Well, I might wonder what's going on up there.
Okay, you mean right there, perhaps? It's hard to see.
Well,
this is not fair because
see, I've got a light shining in my eye.
He's got a light shining. I'll give you even a little bit more help. Let's magnify that.
Oh, good. Whoops.
Can you see those at all? Here, take a look.
Yep.
Over here. So these showed up on the mammogram just as an incidental finding.
Well, I think those are calcifications that you have to be concerned about. I'd like to look at it in another projection, but my guess is that they're going to go on to biopsy.
Yeah, that was kind of our idea too. And she had not only the bloody nipple discharge, but she has this cluster of calcifications, which appears to be in an entirely different quadrant of the breast, or at least a different lobe. So she was invited to have surgery, and she respectfully declined because at that point the discharge had disappeared. Discharge was gone. And she said, you know, discharge is gone. I'm really not going to worry about this. And so nobody pursued it because she was so adamant about this. So she came back now a year later for her next screening mammogram because at this point the discharge was gone. And she presented like this to one of my partners who didn't really know the history, hadn't taken the time to pull out all the films and everything. And at this point, calcifications were here and looked like that. Just to refresh your memory, Bill, this is how they looked a year before.
Not a lot of change, probably a few more. Well, really not a lot.
This is the old, this is the new. Old is on the right, new is on the left.
Actually, if anything, there are fewer of them.
Yeah, this was observed as at least no change, probably less. So everybody just relaxed. Yeah, they're going away. That's good, right? So here we go. Now it's 2002. A year later, here they are here, and I'll blow them up for you again. 2002. And now we go, just again to refresh your memory, here's how it looked in 2001. Here's how it looked in 2000. It's all about the same magnification. This is all optical magnification, of course, because nobody was doing mag views on these at this point. So what do you think?
Well, again, it seems like if anything, it's decreasing.
Yeah, very reassuring.
Yeah.
Yeah, they're going away. Okay, well, that's interesting. So here now we go to 2003. Here they are again, and I'll magnify them for you. Whoa. And so here's 2002, 2001, and 2000. This is over 3 years' time. What's happened?
One by one, they're going away.
They're going away. And everything looks pretty good. So, hey, this is wonderful. No more discharge, no more calcifications. Must be off the hook. Until 2004. You knew there was a catch, right? And now we've got a problem because not only do things seem to be increasing in density, which I think you can appreciate there, Bill, but now we have a little bit more help. Nobody put a BB on this, but she has a palpable lump, and you guessed it, it's right at that spot. So what would you like to do at this point?
The spot mag and sono.
Let's do that. CC and MLO views.
More calcifications. They went off and got their buddies. And,
yeah. Got the reinforced.
They're back with some areas of density and maybe even some speculation.
Yeah, and what about some of these other calcifications?
Well, they're very pleomorphic and linear forms.
So it's got a palpable lump. She's got this increasing density, increasing calcifications at this point, some of which look certainly pleomorphic. With the palpable lump, what else can we do to characterize the area better?
Another view, sono.
Sono would be good. Here's the calcifications on the area of increased density. Here's a little architectural distortion. Here's the ultrasound.
It's mildly suspicious.
You are a quick study. 1.9 by 1.6 centimeter mass. For further evaluation preoperatively, we also did an MRI, and I'll just show you this briefly. This is one of the subtraction views, the T1 weighted sequence with the CAD stream applied for just showing the different curves, the time intensity curves. And just to show you these two areas right around where we saw the mass, there's a skin marker on the palpable lump. And here are the time intensity curves. You can see these, as you will find out if you don't know already, over the next few days, that these are malignant type curves going up quickly and coming down quickly. So at this point, working diagnosis is something bad. Yeah. So, and in fact, it was indeed. It was a 2.2 centimeter invasive ductal carcinoma, high nuclear grade, and as not unexpectedly with extensive high grade DCIS, 2 out of 16 nodes positive. Give this tumor long enough, it's going to go other places. So, what's the take-home message here? Should disappearing calcifications with any suspicious features be ignored? What's the answer? Hope we learned a lesson here. Never. Why do I say that?
Well, we've all seen some big, round, classically benign dystrophic calcifications that dissolve over a period of time, and you wouldn't be concerned about those.
Those aren't suspicious.
But these are punctate calcifications that are not classically benign, and they're beginning to go away.
And some of these were linear. Remember, initially, they were pleomorphic from the outset, and I think that was the big mistake. And it's something we all. I don't know, people just aren't maybe aware of it, but Dr. Tabar has been talking about for a long time, the so-called disappearing calcifications. What's happening on a microscopic level? Most likely, the tumor, as it grows and begins to invade, the pH changes in the area, the calcifications, the calcium within them is either devoured by the tumor or is resorbed and actually disappears. But that is not a good sign. That's a bad sign. It means the tumor is starting to invade. And that's the lesson of this case. You see suspicious calcifications, and they start to go away. I mean, assuming you gave them the chance to go away, as unfortunately we did here, then this is not a good thing. And it's an important lesson to remember. Something looks bad, you should take it out. Don't give it a chance. If it starts to disappear, that doesn't mean it's a good thing. And in fact, maybe just the opposite.